Hi everybody, thank you for joining me today. This is part of our ongoing talk about healthcare topics that are important to the community. Today we're going to talk about heart disease. We're going to talk specifically about preventative heart disease. So how do we avoid getting sick in the first place? So I'm Dr. Jonathan Marsh. I'm with Naples Concierge Health. We are a concierge practice. We focus on preventative care. We offer all the services that you see here. And we put these videos out to be a service to the community. Of course, if you are interested in becoming a patient, then you can reach out to us at naplesconciergehealth.com. So today we're going to talk about ASCVD, atherosclerotic cardiovascular disease. So generally speaking, this is what contributes to heart attacks and strokes, which are two of the major causes of morbidity in the United States. So we're going to go over how you determine what your risk is. We're going to talk about the benefits of diet and exercise in detail with some statistics. We're going to talk about cholesterol and blood pressure management, which are the mainstays of medical management. We're going to talk about some of the imaging that's available that might be confusing as you hear about different types of tests and try and clarify that for you. And we're also going to talk about some recent advances in preventing these diseases. So first, ASCVD. So what is ASCVD? ASCVD, generally speaking, is the process where cholesterol gets into the vessels of your arteries and creates an inflammatory reaction, and then you start having inflammation because of that. It happens over your life, over a long period of time, and eventually those blood vessels become blocked. And as those blood vessels become blocked, that's what can cause symptoms of stroke or heart disease or angina. What often happens is that you have cholesterol build up over years, and then you have a thin cap on top of that. And when that breaks off acutely, that's what can acutely cause the heart attack or stroke. Or if this vessel gets narrowed, but it doesn't completely occlude off, you can get diseases from lack of blood flow, like peripheral vascular disease or angina. So ASCVD is not just heart attacks. It can affect any part of the body that has blood vessels. So when the arteries that supply blood to your heart block off, that's a heart attack. When the arteries that supply blood to your brain clot off, that's a stroke. If the arteries that provide blood to your extremities clot off, that's peripheral vascular disease. And this can also be part of chronic kidney disease, as the small vessels in the kidneys get occluded and prevent the kidney from working correctly. So as far as impacts on the heart, it's not just a heart attack. A heart attack is when acutely one of the blood vessels clots off because that thin cap on top of the cholesterol plaque breaks off and a blood clot forms there, and acutely you lose blood flow. But you can have what's called microvascular disease when the small vessels of the heart block off, and you can have vessels be chronically occluded and cause angina, or cause congestive heart failure from chronic lack of blood flow to the heart, or as a sequelae of a heart attack. So it's not just the acute heart attack, but it's also congestive heart failure. It's also angina. It also can be, fatigue. The impact is not just the acute heart attack. So what are the risk factors for ASCVD? So the biggest medical ones that we think about are hypertension, which affects 1 in 3 adults, which is very common. Another common one we think about is high cholesterol. We think that high cholesterol contributes to 40% of occurrences of heart disease. Smoking obviously is a risk factor. It's pro-inflammatory. It makes these cholesterol plaques worse and more likely to rupture. Diabetes, metabolic dysfunction, more broadly speaking, is associated with increasing the risk for ASCVD, because when you have metabolic dysfunction and diabetes, your cholesterol becomes suboptimal, and that contributes to heart disease. And then finally, obesity goes hand in hand with diabetes. It's linked to a 50% increased risk in ASCVD. Diabetes increases your risk 200 to 400%. Smoking is responsible for 30% of cardiovascular deaths. So you might be asking yourself, how do I know if I'm at risk for ASCVD? What sorts of factors play into this? So One thing that your primary care doctor should be doing once a year is a calculation with one of the many available risk calculators to determine what your 5 or 10-year risk of ASCVD is. So typically this is a calculator online. There's a few different ones, and it takes into account your cholesterol panel, your blood pressure, your family history, maybe even your waist circumference, depending on the one specifically used, and it spits out a number that says your risk of ASCVD in the next 5 years is 5%, 10%, 20%. And then there's guidelines regarding these that dictate if they consider you a candidate for treatment in the usual sort of medical pathways. So here we talk about also age is a big factor. Gender and race also play into this. So if you know you're high risk because of these calculators or because of family history, or even if you just want to be really preventative and aggressive with expanding your health span, how can you help prevent ASCVD from developing? The first and most important thing, and it's not a medication, which is great, is increasing your physical activity. So some statistics around physical activity. Firstly, if you're able to maintain a 95th percentile in your VO2 max, which is a measure of your body's ability to use oxygen, it's basically a measure of your exercise capacity, you are going to live 4.9 years longer on average than if you are unable to do that. And obviously you have to have a healthy heart to be able to maintain that sort of level of fitness. Now, 95th percentile, that's a lot. Only 5% of us can get there, so what else could we look at? Moderate intensity exercise, which sometimes we think of as zone 1 or 2 exercise, but just doing that 150 minutes a week can reduce your risk of mortality by 27%. So that's not a lot. That's not going out and running triathlons. That's just having a healthy, active lifestyle. They've also looked at people who just consider themselves active versus not active. And people who classify themselves as active have a reduced risk of ASCVD as well. So anything you can do to get out there and get moving, even if it doesn't affect actually your weight or your diabetes, all of these things have a mortality benefit. So how much exercise should you get? Ideally, 150 minutes of moderate exercise a week. So that's 30 minutes, 5 days a week. As I said before, any exercise is better than none. Any sort of movement is better than no movement. There's no real cap to how much exercise or movement is best. There have been some conflicting studies about people who do ultra marathons and those sorts of things. But for the average person, more is better. Strength training, independent of the aerobic training, can improve your mortality benefit as well. So let's talk about lifestyle modifications. Again, these are things we're doing to prevent the development of ASCVD. Obviously, stopping smoking is really important. As we mentioned before, smoking increases your risk of heart disease 2 to 4x, 200 to 400%. Stress management. So to put some numbers on that, it's easy to say, oh, get sleep, don't take on too much stress. But chronic work-related stress increased the risk of ASCVD by 50%. So these things are really impacting your health. The mind-body connection is real, and this is an example of it. To make these things doable and sustainable, it's important that you incorporate them into your lifestyle, replacing dinners with walks as a reward, for example, coming up with non-food rewards or coming up with exercises or activities that you and your spouse or your loved ones enjoy. Integrating it into your life is really important for making these changes sustainable. For dietary benefits, so the diet that's been studied most is the Mediterranean diet, which has been shown to reduce your risk of ASCVD. Other things, and this some people argue is the benefit of the Mediterranean diet, is having enough protein and fiber. If you're getting enough protein and fiber, a lot of times that can crowd out the less healthy foods in your diet. Avoiding ultra-processed foods is really important. There's more and more evidence coming out that ultra-processed foods contribute to inflammation, contribute to this atherosclerotic plaque being more likely to rupture and more likely to form. So those are some of the basics you can do to get your diet under control. Eliminate ultra-processed foods, try and get enough fiber, 30 grams a day, try and get enough protein, which should be at least 1 milligram per kilogram, sometimes up to 1 milligram per pound. For each 5-unit increase in BMI above 25, your risk of mortality increases by 49%. So every little bit counts. Maintaining a healthy weight is really important for avoiding mortality. We're talking about ASCVD here, but also it impacts your risk of cancer, it impacts your risk of dementia. So this just cannot be overstated how important it is. So as far as preventing ASCVD from occurring in the first place, there's 2 big medical interventions that people look at. One is managing your cholesterol or your lipids, and the other is managing your blood pressure. So let's talk about lipid management first. So the first thing you're going to do is check blood work and see what your lipids are doing. So not only do we want to check the LDL, the total cholesterol, and the triglycerides, which are part of the basic panel, but also we want to check the ApoB, which is a lab that looks at the protein that helps make your LDL and tells us what its behavior is going to be like. So LDL, as you may have heard before, is bad cholesterol, they call it. The goal is at least less than 100. More and more people are pushing to get this less than 70, maybe even less than 50 if you've had a history of a heart attack before. We're talking about people without heart disease initially here, but these are the lipid goals, and more evidence is coming out that there's not really a bottom number for this. So the lower you push it, it seems to be the better you do. As you get your LDL down, your total cholesterol is also going to come down, and the goal for that would be less than 200. Then what you do is, if your LDL is at goal, you might want to check an ApoB and see if your ApoB is actually at goal. Sometimes the ApoB is still high and might warrant using a more aggressive measure of your, or a more aggressive treatment for your cholesterol. So here we go, standard panel, HDL good cholesterol, LDL bad cholesterol. It's like triglycerides are fatty particles that float around. We don't talk about those as much, but for some people, it runs in their family that their triglycerides is quite high, and then there's a total cholesterol goal. So to talk about and show the ApoB a little bit more, so ApoB is a protein. It aids in the transport of cholesterol, and by measuring your ApoB, you're actually getting a total of not only the LDL, but something else called the VLDL, basically all the bad cholesterol. And the amount of ApoB is directly proportional to the amount of bad cholesterol. So it is a good lab to double check at least once a year. There is another cholesterol particle that is getting a lot of press that's really important. It's called the Lp(a). So Lp(a) is another type of cholesterol particle. It's highly correlated with heart disease. It tends to be more genetically driven. So diet, weight loss, unfortunately, medications do not have as much of an impact on Lp(a). It is good to know if you're someone whose Lp(a) runs high, because that is going to make us mentally know that you're a higher risk patient than we would have thought otherwise. Right now, there are no medications for Lp(a). However, there are medications in development to see if we can drop this lab value and therefore reduce your risk of stroke and heart attack. So we advocate for checking these extra tests so that you have all the information you need to know how to manage your risk. Another lab you might see is something called the lipid fractionation panel. So this is how big or small your lipids are. So you want big floppy lipids like HDL tends to be. If you do have LDL particles, you want them to be big and slow as opposed to small and fast, because the big slow particles are less likely to cause inflammation by penetrating the walls of the arteries than the small fast ones. This does tend to mirror your total cholesterol, bad cholesterol numbers, your LDL numbers, and we do tend to see this improve as our other cholesterol numbers improve as well. But again, this is extra information. It can give you an idea of how risky your particular set of cholesterol numbers is. So how might you treat the cholesterol? First of all, diet and exercise, diet and exercise, diet and exercise. If you are able to lose 10 or 15 pounds, your blood pressure will go down and your cholesterol panel will improve. We see it all the time in the clinic. We have people who come in and are really focused on improving their lifestyle. A lot of times they're new retirees and they can finally focus on their health. That will improve your lab values. But if we've done that, we've tried everything, and we're still seeing lab values that indicate that you're a high risk for stroke and heart attack, it is time to start thinking about medications. So basically I have a few different classes of medications. There's actually a number of these, but they're not all commonly used, so we'll just touch on the most commonly used ones. The first one are statins. Statins are HMG-CoA reductase inhibitors. They make your liver make less cholesterol. The next ones are cholesterol absorption inhibitors. This is like Zetia. So some people, the issue is their liver is making too much cholesterol. Some people, the issue is their stomach is absorbing too much cholesterol, or their gut rather. So Zetia works really well for a subgroup of patients. Statins work really well for most patients, but sometimes we'll see dramatic improvement by adding a Zetia. If with those two medications you're still not able to get under control, you might consider a PCSK9 inhibitor. These are the injections. These are really potent and will drop your cholesterol if you are someone who's still running high despite those other two medications. Some other classes to consider, there's fibrates for if your triglycerides specifically run high. There's niacin, which tends to be more triglyceride specific. There's bempedoic acid, which we also use sometimes as well. So risks and benefits of statins. So statins are one of the oldest, best studied medications there are. So they, as we mentioned, reduce the synthesis of cholesterol from your liver. They have outcome evidence showing that people on statins are less likely to have a second heart attack if they've had a heart attack. They're less likely to have a heart attack if they've never had a heart attack. They flat out work. The issue is some people have side effects with statins, so up to 10% might have myalgias. There's a number of different statins available now, so doing trials of different ones to find one that works for you without causing side effects is a great strategy, and usually we can find something that will work for a patient. And even if we're not able to get on a high dose of statin, we're able to just get on a little bit of a statin, that still carries not only does it fix your labs and your cholesterol, it carries a mortality benefit. So it's really important if you're high risk that if you're not able to get things under control with nutritional and lifestyle modifications, that you do move on to the next step. So Zetia, we talked about ezetimibe. It helps reduce the absorption of cholesterol from your gut. It reduces your LDL really well. There was a study out recently showing that Zetia and the statin together worked better than just the statin. So if you're not able to get your cholesterol down into that sub 100, maybe even sub 70 level, depending on how aggressive you want to be, or if statins are giving you side effects of myalgias, you're not able to tolerate them for any reason, then adding Zetia can be a good way to do that. And there's no cross-reactivity between Zetia and the statins. Zetia does not cause muscle aches or pains or myalgias, and it works really well along with statins for that reason. PCSK9 inhibitors generally are used if we're not able to get things under control with the other two medications. They have not been as well studied as statins as far as reducing risks of heart attack. Usually they're studied in conjunction with statins and or Zetia, but they do work if you're unable to get your cholesterol under control. These will dramatically drop your cholesterol. And of course, they've studied them and shown that they reduce risk of heart attack and stroke. So that's a quick overview of cholesterol management. So let's move on to blood pressure management. So getting your blood pressure under control is really important for avoiding strokes and heart attacks. So if your blood pressure is running 10 millimeters of mercury high on the top number, the systolic number, you have a 53% increased chance for ASCVD. So those are pretty big numbers. blood pressure, like cholesterol, responds to lifestyle modification. So getting enough sleep, losing weight, getting metabolically healthy, eliminating highly processed foods, especially if you're able to drop 10 or 15 pounds, your blood pressure will come down for most people. So blood pressure control results in a 50% relative risk reduction in the incidence of heart failure, or 30 to 40% relative risk reduction in stroke, and 20 to 25% risk reduction in MI or heart attack. So those are big numbers. This is not something to be ignored. So if you do have high blood pressure, first of all, diet, exercise, maybe a low sodium diet, getting enough sleep, eliminating stressors, all of these things to help bring it under control are really important, and then you don't run the risks of side effects with medications. That having been said, some people, even if they're at a healthy weight, some people are unable to get to a healthy weight and they still have high blood pressure. So our first line choices for medications are what's called ACE inhibitors and AR2Bs. Calcium channel blockers are another first-line medication, and diuretics are another first-line medication. The choice between these when someone is starting is usually based on their side effect profile. Sometimes their blood work, like if your potassium's running high, you might not choose ACE inhibitor first. Or if you're out in the sun all the time, diuretic is a water pill. It might make you prone to getting dehydrated if you play golf 5 times a week. So that's usually how we choose which one of these to do first. A lot of people require a little bit of several different medications to control their blood pressure. So there are combination medications available so that you're not taking extra pills in that setting. But often it does take more than one medication to get the blood pressure under control. Depending on how high you start is also going to be a driver on how many medications it's going to take to control your blood pressure. So someone starting out with a blood pressure of 190 over 90 is going to require more medicine than someone starting out at 150 over 90 or 80. The other thing is if you have really severe high blood pressure, especially at an early age, it might be worth doing what's called a workup of secondary hypertension. So this is looking for medical conditions causing your hypertension as opposed to just age-related hypertension. So ruling out hormonal conditions like hyperaldosteronism or a renal artery stenosis, which can also lead to very difficult to treat hypertension, is important in select patients. In the office, we're constantly dealing with this question, and it's really a fair question, which is white coat hypertension. So often people go to the doctor's office, they get rushed into a room, they were just in their car, they sit down, somebody measures their blood pressure over their shirt sleeve, and then the doctor comes in and says you have high blood pressure. I would encourage you to say, no, that's not the right way to do this. So for blood pressure to be accurate, it's supposed to be on the arm, it's supposed to be on the skin, the blood pressure cuff is supposed to be the right size, you're not supposed to be talking, you're supposed to have 3 to 5 minutes ahead of time to sit still and rest, and all of these things are important for getting an accurate blood pressure. Sometimes that's just not possible in the clinic. Some people are just stressed out by being in the clinic, and it's a perfectly acceptable substitute to measure your blood pressure at home with a at-home blood pressure cuff with all the precautions I just talked about, and email, text, call your doctor with those numbers, and that is a perfectly legitimate way to measure blood pressure. So if you're home at the doctor's office but not at home, or when you check it at CVS, let your doctor know, because we don't want to overtreat. If we treat your blood pressure to too low of a number, it's going to make you fatigued, you're not going to like it, and you're going to quit going to the doctor. So we talked about diet, we talked about exercise, we talked about the 2 main medical conditions that need to be treated to help reduce your risk of ASCVD. Now let's take a little bit of a change and talk about some of the imaging studies that get commonly ordered, what they are appropriate for, and help just educate you on that, because I do see a lot of confusion around cardiac imaging and what each test is for and does. So a very popular test is the coronary calcium score. So the coronary calcium score is a test to help us risk stratify people. So if you are someone whose cholesterol number is 100 and we're trying to decide, are you high risk or low risk? Your LDL, your bad cholesterol, is 100, but your father had a heart attack at 45. Do you want to treat aggressively to be less than 70 or less than 50, or are you low risk? Well, the coronary calcium score can help understand that. So it is a CAT scan of the chest. It looks at the calcium that is in the blood vessels and arteries of your chest, and that correlates with your risk. So if your score is 0, that is a good sign that you are low risk for a heart attack in the next 10 years. If your score is greater than 300, that is a sign that you have ongoing inflammation and cardiac risk, and you might want to consider being more aggressive with your treatment. If you're somewhere in between, hard to say what it means. If you are older, a score of 0 is very rare. So the point being that to interpret these can be somewhat difficult. It can give you a clear answer, you're very low, or a clear answer, you're higher risk. Sometimes in the middle, it's really hard to interpret what to do with this test. The other thing about the coronary calcium score is that it does not necessarily need to be tracked year over year. I frequently have patients who get a high coronary calcium score. For that reason, they're following with the doctor. They get put on a statin and they say, oh, but my calcium score is going up, it's not working. Well, calcium in your artery is atherosclerosis, so cholesterol that is hardened and is now settled down. It's not inflamed. It's not at risk for rupturing anymore. So by using the treatments that we've talked about, what we're hoping to do is move your plaque in your heart from acute and likely to rupture to stable and less likely to rupture. And that means that sometimes the coronary calcium score continues to go up even though your cardiac risk may be going down. So really this test is best when it's in someone who's medication naive to determine what their cardiac risk may be. And again, if you already know you're high risk, you already know you're low risk, then the utility of this test, it can be difficult to interpret. This is actually not a risk stratifying test, but it's a test we get asked about all the time. So nuclear stress testing, or an exercise nuclear stress test, or an exercise stress test even for that matter. This test is not really assessing your future cardiac risk. What this test is telling us is if you have an area of your heart that is not getting enough blood flow. So this is not a cardiac risk stratification test. This test is appropriate if you're having chest pain or having shortness of breath, and we want to see if it's lack of blood flow to part of your heart. This is not to determine if you are at risk for a heart attack in the future. If this test is normal, your odds of a heart attack in the next year are very low, but really this test is to uncover if your symptoms might be from heart disease as opposed to something else. CT coronary angiography. So CT coronary angiography is a CAT scan with IV contrast, so it has a fair amount of radiation and it does have some IV contrast that looks at your heart blood vessels, the actual coronary arteries, and you can see the great images that they get here. So this can tell us if your heart has any blood vessels that are blocked off. There is some evidence that this can help risk stratify people. There's also now, in addition to this, something called the Clearly score, which is when they look not only at the calcium in your arteries and if your arteries are open, but the amount of plaque, soft plaque that's in your heart. And this is the only test that can really see that. Now, the issue with this is that it has not been well studied, like the coronary calcium score, to say that you're high or low risk. And additionally, if you do find the plaque that's, quote, hot, meaning it looks like it might rupture or it's got a thin epidermal layer on top of the plaque, right now there's not really an intervention that they do on that. So it is an interesting test. Some people who are really super high risk want to see this test. It's not something that's being ordered routinely at this time. Cardiac PET imaging is sort of like a stress test, except you get better pictures in that this shows blood flow to the heart. So again, this is for determining if you are having active lack of blood flow to part of your heart because the blood vessels narrowing. You know, if you have symptoms, are they from my heart or are they from something else? Cardiac PET is good for that. It's not necessarily good for risk stratifying you in the future. Here we talk about the Clearly score. This is what I mentioned before. A Clearly score uses artificial intelligence to count the pixels on the CAT scan that are not only hard plaque and a calcium score, but also soft plaque. and there is hope that this will help us with better risk stratification. It's still in its early phases though. So we always get asked about supplements. So let's talk about some common medical questions that we have regarding ASCVD and supplements. Aspirin, not really a supplement, but in the past, aspirin was recommended for pretty much everybody for reducing the risk of heart attack and stroke. Subsequent studies have not borne out that benefit. So people on aspirin had an increased risk of bleeding issues and also cancer for some reason. So we don't routinely recommend aspirin anymore. Sometimes if you're particularly high risk with a super high calcium score or some of the markers for inflammation we might measure like CRP or MPO, we might put you on aspirin briefly, but it's not recommended for general prophylaxis any longer. Common supplement is omega-3. There are medications based off of omega-3 like Vascepa. It's been studied. Some studies have shown a benefit. Some studies have not shown a benefit. I saw, in the paper the other day, omega-3 helping with dementia and helping with behavioral issues even in kids. So omega-3 can reduce triglycerides. It's been studied a lot. None of it has shown a clear trend towards a benefit or not. So for me, this is one. Take it if you feel like it will help you, but you don't have to take it. Might be a waste of money, but it's not going to hurt you. Vitamin D. We still recommend for bone health, in particular with calcium. It's also good for avoiding falls and injuries from falls. As far as ASCVD goes, there's not evidence that it reduces occurrence of ASCVD, and they have studied that. 5-10 years ago, they were recommending it to help prevent ASCVD, but no longer. Red yeast rice shows some decrease in your cholesterol levels. It has a low dose of a chemical that is related to lovastatin, so there is a good medical rationale for using it. It hasn't been proven to reduce your risk of a heart attack, but again, it's not going to hurt you. Coenzyme Q10. So in some heart failure patients, there was some evidence that it might help them, or you can use it as a supplement if you're having muscle aches or pains because of your statin. So it can help with either of those. So takeaways: 1, lifestyle, maintain a healthy weight, diet and exercise. All of these things reduce your risk of ASCVD if you add up all the numbers by like 50 to 60%. So as efficacious as managing your cholesterol with medications or managing your blood pressure. That having been said, if you need the medications, they are well-studied medications with good long-term evidence that they will help you live longer and avoid medical issues in the future. As far as monitoring, getting your routine blood work, making sure you know your risk from those risk calculators. You can consider a coronary calcium scoring to help ascertain your risk if you're in sort of an intermediate area. The routine stress tests, routine CAT scans, routine PET scans are not recommended for most people. There are a lot of reasons that you might end up getting one of those: because you're fatigued, because your energy is low, because you have bad heartburn, that might be chest pain. A lot of people do end up with those tests, but they're not strictly what's indicated to help risk stratify you for cardiac disease. So thank you for listening to our talk. I hope that this was informational and that you got some good takeaways from this. In June, we are going to talk about cancer prevention and advanced strategies for cancer prevention. There's a lot of tests out there, mainly whole body MRI and Gallery Grail tests, and we want to help you make an informed decision regarding those. And then we're going to do something new. We're going to ask later in the summer what people would want to hear us talk about, what questions they have that they feel like there's information lacking out there. So thank you very much for your time. Reach out to us if you need anything, and have a good day.